Hi, it's Dr. Centeno, and today we're going to talk about a few things. We'll talk first about our new lumbar degenerative disc disease study at Regenexx, which will be a randomized controlled trial. And then we'll also talk a little bit about some C2 imaging insights, kind of hot off the press there. Just kind of saw an interesting CT scan or CT venogram when I was with a patient this morning. So I wanted to share that because it brings up an important topic. Can we image some of these subtle nerve injuries that we know happen, but are otherwise impossible to diagnose other than just clinically, meaning impossible to see? As usual, I'll start with a short time where I'm going to give a lecture. And that'll be maybe first 5-10 minutes, something like that. And then we'll go to questions. Questions can be about what I'm talking about. They can be about any topic at all, totally up to you. So let me go ahead and share my screen. And then I am going to start this little presentation here. So today, again, we're talking about our platelet lumbar degenerative disc disease study, randomized controlled trial. Plus, we'll talk about some interesting CCI imaging. So degenerative disc disease, or DDD, is pretty common. That's kind of what happens when your low back starts to degenerate. You start to see disc bulges. You start to see vertebrae that go one way or this way on the other. So if we try to line up the back of these, they don't line up. There's another disc bulge here, another disc bulge there. I'm sure if we took a look, we'd see some facet arthritis back here. So that's degenerative disc disease. Very, very common problem. And if physical therapy doesn't help and the person continues to have issues, there are a few interventional things that can be tried, but for the most part, they give temporary relief. So when it comes to more long-lasting relief, patients often move towards a lumbar fusion. So this study is a randomized controlled trial, or RCT. A patient will be randomized into either getting the real treatment or a sham procedure. That means they get put to sleep without injecting the platelet-based products that will form the core of this procedure. And this is going to be high-dose PRP into facet joints, platelet lysate / dextrose into the ligaments, platelet lysate with nano-dose dexamethasone around nerves or epidural, and platelet chloroplasma into areas of multifidus atrophy. We'll be measuring the outcomes, and if you end up in the sham group, you can cross over to the real treatment group after a certain period of time. So one way or the other, you're going to get a no-charge treatment here. Now, like all of our studies at Regenexx, and we have done now, this will be our 5th randomized controlled trial. We're looking for patients who have been offered, in this case, a back fusion, who only have that problem, meaning not superimposed to other issues, and who haven't had recent steroid injections or radiofrequency ablation, no prior back surgeries, and without a bunch of other medical problems. So for instance, if you had EDS, you would not be a candidate for this study, or if you have lupus or something like that on top of a back problem. So moving forward, again, this is a no cost to you medical study, so important that you understand that. That's obviously for only study-related care. And if you think you might qualify, this is who you contact, edotson@regenexx.com. And she's our clinical research coordinator, so she can go through the inclusion-exclusion criteria, which are obviously more detailed than I described, but I wanted to give a 30,000-foot overview of what this study was about. So please reach out to Erin if you think you're interested. This is a study that'll probably take a little while to recruit, but obviously that's why I'm talking about it today, because we want to get our the message out there that this is available to patients. So then the second half of my short talk at the beginning of things today is can we see the C2 DRG, or what's called dorsal root ganglion injuries on imaging? You know, seeing nerve injuries on imaging is usually not that easy. There is a special type of imaging that we can get called an MRI neurogram. It's pretty expensive, but we've done that a few times because it's not bad at seeing some of these injuries. So we're talking today about a C2 dorsal root ganglion, or in other words, the C2 spinal nerve, or the sensory part of the C2 spinal nerve. So the skull up here, we've got C1 there, we've got C2 there, and then this nerve right here that comes out right in back of the C1, C2 facet joint. So this is the C1, C2 facet joint, is called the C2 dorsal root ganglion. And it's the one that supplies the sensation to the head. So if you mess with this nerve here, or if you injure it, you're going to get some pretty bad headaches. And if you injure the C1-2 joint or the C2-3 joint below it, or even the 0-1 joint, which are, so this is the 0-1, and this is the 2-3 joint here, you can get dizziness, vertigo, imbalance, all of that good stuff. So we know that the C2 DRG, if it's injured, can cause headaches. The problem is, how do you see if it's injured? Well, we know from studies that were done by Taylor and Twomey, and these guys are out of Australia. And what they did is they took people who died usually of blunt abdominal trauma, meaning they didn't die of a neck injury at all. And then they went ahead and they were able to take slices through the neck tissue to try to see what other injuries were there had they survived, right? So they were in fairly big crashes, but because of the way the crash was, it may have done something like burst their spleen. Whereas if the crash was slightly different, then they would have survived. And what that allowed them to do is to look for things like C2 dorsal root ganglion injuries. So we have here, C1 and C2, and this is that biconcave facet joint that we've talked about at C1, C2, meaning a concave surface on a concave surface. And back here, we have the C2 dorsal root ganglion. And what they noted here was bleeding in the ganglion. Now, that's not good, because if the ganglion was damaged enough to bleed, then that person's going to have pretty nasty headaches, and those headaches could be permanent. So we know things like this happen, but seeing them on routine MRI is almost impossible. So this was an interesting patient I saw today. Very nice guy who's a watcher here. He may be on today. That's why I've kind of not showed his name here, because I don't want to get into all of that. But long story short is, this is a guy who was involved in a pretty substantial crash and is having pretty substantial issues and problems. And what was really interesting was I was looking at the CT venogram, and normally looking at things like internal jugular vein, compression, etc. But he didn't really have much going on there, or certainly not something that would explain one-sided symptoms. And I started looking then at the vertebral artery, which is right here. And this is how the vertebral artery goes on these two sides. Now, this is the symptomatic side here. This is the asymptomatic side there. And what was interesting is looking behind the C1, C2 facet joint, for where that dorsal root ganglion lives, those look completely different. Here we can see on the left image here, we can see the C2 dorsal root ganglion is actually surrounded by what appears to be lots and lots of veins. And so I'm going to outline the whole thing here. So a lot of veins are around that C2 dorsal root ganglion. They kind of light up, and then you can see the swollen ganglion here. But on the other side, you just don't see much, right? You get maybe a little bit of a ring of some vessels around a much smaller nerve. But we don't really see all that much. Now, this is what it looks like on MRI here. So that's the C2 dorsal root ganglion. It looks a bit bigger on that side. And then this one, it's hard to see, but you really can't see very much on MRI. But I was interested in how starkly different these CT venograms were. And given that this is the side of his symptoms right here, the question would be, is this allowing us to image that damage we just saw in the Taylor and Twomey study? Because if we theoretically said what would happen to the C2 dorsal root ganglion or C2 spinal nerve if it were injured in a car crash, one of the things that would happen is that the body would try to build new blood vessels around it to give more nutrients to the nerve. But if the nerve never healed, those blood vessels would stay. And that seems to be what we're seeing here on the symptomatic side. So it's going to be interesting to get the information from the radiologist and have them take another look at this, because this wasn't discussed on the study. They were looking for things like vertebral artery compression and internal jugular vein compression. They really weren't looking for extra blood vessels around the C2 dorsal root ganglion. But to my mind, this fits. Now, we'll have to see if his physical exam fits, because I've just talked to him in a telemedicine format. But it is interesting that it seems to me that we're probably imaging at this juncture, 4-year-old C2 dorsal root ganglion injury. And if that's the case, now we've got a pretty good sense of what we can do about it, right? We can direct treatment specifically in that area. And that's half the challenge sometimes with complex upper cervical injuries, is trying to figure out what needs to be treated, why, when, where, and how. So anyway, I thought it was interesting. I wanted to share. Obviously, I'll be looking for this specific issue in a lot more CT venograms, because this was just an incidental finding that I saw in just looking at all of the images. So from there, we will take some questions, either about that topic or anything else that you might be on your mind. So let me go back and go to questions. Okay. Regenexx. It's been advanced by Harry Winston. How many trips to your clinic would be necessary to participate in the study? So if you mean the lumbar DDD study, it's going to be at least 2. If you get into the treatment group, and if you cross over into the other group, it would probably be another 2 if you end up being in the sham group. And that's just luck of the draw, randomization. Mark, do the lumbar facet joint ligaments stabilize the spine? My L4-5 facets get stuck, jammed, and extension. Which structures, ligaments would need to be treated to alleviate this? What ligaments stabilize lumbar spine in extension? Yeah, good question, Mark. Let's see if I can get some lumbar ligaments up and we can take a look at it. Let's see if we can find a good picture here. This is one of our pictures from the back. So Mark, I'm going to try to put 2 different pictures up here just so that we can take a look at ligaments from different angles. Because there are lots and lots of lumbar ligaments to consider and talk about here. Almost there, Mark. Okay, that'll work well enough. Okay, let me share my screen. here. Okay, so now we have a bunch of ligament pictures up here. So lots and lots of ligaments to think about. Kind of from the back here in the middle, we've got supraspinous, interspinous ligaments, and those ligaments would prevent one vertebra from moving forward on the other in flexion. We have these intertransverse ligaments that would prevent the vertebra from moving side to side on each other. There are also facet capsular ligaments. Now those tend to be not as strong as some of these other ones, but they may provide some stability. And then we've just got an amazing amount of ligaments around the SI joint. Now, regrettably, I didn't put an anterior longitudinal ligament up there, but bottom line is when you're going into extension, the anterior longitudinal ligament may be one of those ligaments that can help to stabilize that motion. In addition, the back muscles and the psoas muscles, or the multifidus and psoas muscles, are going to also do that. And the disc may play a role. So those are all the different things that might be an issue. So if we were looking at the front side, and regrettably I didn't put that up, the anterior longitudinal ligament comes down this way. And then obviously this is the disc here. So those are some of the things to think about. So let me get out of that. So those are the ligaments we might think about, Mark. In addition to that, getting to the anterior longitudinal ligament isn't trivial. We'd have to go through the disc to do it. So it's not a trivial thing to treat. Anna, hello. Are you planning on doing a study on EDS patients as is one of the most common causes of instability? Thank you. Or I'm sorry, Anya. Not at this time. That may happen in the future for sure. But I think we want to get through our traumatic CCI study first before we do that. Charlene, I have issues on both sides of my spine, CCI on top of DDD on the bottom. Is that common? Sure, we definitely see that for sure. So we definitely see patients who have lower cervical degenerative disc disease, which may be symptomatic. I saw a patient like that today, this morning actually. And also probably has CCI. The question is, you know, what I told her is we're going to now have to, once we confirm CCI, we're going to have to perform a hands-on exam and have an in-depth discussion on whether or not the symptoms look more like they're coming from the upper neck, lower neck, or both. And obviously that will determine treatment. But just realize just because it's on an image doesn't mean it's causing symptoms. So that's a very important thing to understand. So we're going to have to use a hands-on exam to thread that needle, if you will. Goldie, what area of sacrum causes pudendal neuralgia? Not necessarily an area of the sacrum, but let's see if we can put up something about the pudendal nerve and take a look there. Okay, this is a nice image here that hopefully should explain what we're talking about with the pudendal nerve. So pudendal nerve is interesting because that's the nerve that generally goes to the genitals. And we certainly have patients that have genital problems. Obviously, the anatomy down there is a little different from men to women, but the nerve kind of travels in similar places. So let me go ahead and share my screen here. And put up that image. So this is the pudendal nerve, and a couple of important things to consider. Number one is that the pudendal nerve comes from the sacral nerves, and so those nerves can get irritated up here at L5-S1, and if they're irritated L5-S1, then the place to treat that is obviously with an S1 or caudal epidural, meaning around the nerves. So even before that becomes the pudendal nerve. Then realize the pudendal nerve goes underneath this ligament, which is the sacrospinous ligament. So sacrospinous ligament, that's another area where the nerve can get entrapped. And then it goes through this canal, this lesser sciatic foramen, and then comes out and then goes anteriorly either into the penis or into the female genitals there. So if we look at the most common things we see with pudendal nerve entrapment in the sacrum, that's either up here at L5S1, and so that would be something like a central L5S1 disc bulge irritating the descending sacral roots. Or we can see things like in here, tarlovs cysts can sometimes do it. So that's another thing that we see. And then if the SI joint is unstable, this sacrospinous ligament can get yanked on, and that can irritate the nerve as well. So the most common place we end up treating would be at L5S1, caudal in the sacrum around the nerves, or as the nerve ducts underneath the sacrospinous ligament here, right there. So that's kind of a tutorial on sacrum and pudendal nerve entrapment, but that's got to be looked at on physical exam. All the imaging has to be looked at, etc., to figure out what's best to treat where in that particular problem. And that's the kind of issue that would cause genital type pain. So if you've got issues like that, pudendal nerve is something that could be involved. Stacy, I have a Harrington rod with hooks, T4 through L4 for scoliosis since 1983, and currently get prolotherapy for occipital to sacrum twice a year, and very much proactive with working out. I have cervical spondylosis. I live in Highlands Ranch. I would be interested in any studies I would qualify for. No studies that we have open right now for someone like that. So nothing that we have open at the moment for patients that are in that situation. But I think what you're bringing up is that you've got a lot of overload. Sounds like above the fusion and probably below. So treating above and below is probably helpful. Carrie, has there been any evidence that PICL is helping to correct the CXA or other CCI grab oaks? And so what degree of correction after how many treatments? You know, Carrie, the biggest thing we've looked at is changes in C1, C2 overhang. And there we tend to see about a 1/3 improvement with each treatment. Now, patients can do better than that or worse than that, obviously, along a bell curve distribution. But when it comes to that, just so that we're clear, that's the active measurement, because what you're talking about here are static measurements. Instability obviously is an active concept, right? There is no instability without motion, because that's what instability means. It's things that are unstable with movement. So a clavicoaxial angle is not doesn't have anything to do with motion, and nor does a grab oaks. Those are just static measurements that could indicate CCI, but don't allow us to really diagnose CCI. In order to diagnose CCI, we need motion. So the one that we tend to follow would be a C1, C2 overhang. And yes, we've got objective measurements now in dozens of patients showing that we see decreases in that type of instability, C1, C2 overhang. Stacy, can anything other than iodine be used for a venogram? Stacy, I think there's some confusion here. If we look at the type of contrast that would be used either in an X-ray guided procedure or in a CT venogram, it's not really the same thing as an iodine based product that used to be used in something like an IVP, let's say back in the day. So an IVP study used to be done to look at the kidneys and how they were working and all the way down the ureters, etc. And sometimes women who had a lot of urinary tract infections would get these studies way back when. And those studies used a very high iodine content, specific kind of iodine dye that a lot of patients were allergic to. When it comes to the stuff that's used in a CT venogram, that's very similar to the stuff we use in X-ray guided procedures. So if you've had X-ray guided procedures using contrast, and had no issues with that, it's really the same stuff. Ryan, I enjoyed the info on the accessory nerve earlier this week. Can it cause the SCM upper trap to tighten up and then cause CCI? How often does hypomobility of muscular structures cause hypermobility of ligamentous structures, specifically the upper cervical area? Yeah, Ryan, not that often. Now, certainly what tightness in various muscles can cause is joints that move abnormally. And that over time can lead to the type of wear and tear that can cause arthritis for sure. But when it comes to tearing ligaments or damaging ligaments, we don't tend to see that as much with hypomobility or muscles that are in spasm. In fact, we tend to see it go the other way, where hypermobility or instability leads to spasm. Goldie, yes, I have a tarlov cyst. Yeah, so Goldie, the question would be, is that tarlov cyst impacting the descending sacral nerve or the exiting sacral nerve? And does that need to be treated with the pudendal nerve? Because those are the nerves that make up the pudendal nerve. So the nerves can get irritated before it becomes the pudendal nerve or after it becomes the pudendal nerve. So that would be the big question to answer in your situation. Stacy, what can be done with over 39 years of damage to my neck to keep me from getting worse? I have more pain in my neck and shoulders as I age. You know, Stacy, I'd have to take a look at your stuff to be able to say that. I think you said you were in Colorado, so it might be good for you to come in and have us take a look so we can try to see what's going on with you specifically. Is it hypermobility within your shoulders, for example? How much damage is in the neck? You know, it sounds like you're doing simple prolotherapy injections. So if that gets upgraded to something like platelet-rich plasma, can we move the needle more? Those are all open questions until we look at your imaging and do an exam. Sure, Goldie, happy to help. I think when you're talking to a doctor about that pudendal nerve issue, you want to make sure that they're having that type of conversation with you. What are the contributions from my tarlov cyst and or L5S1 disc and or SI joint instability that may be yanking on that sacrospinous ligament that may be pissing off the pudendal nerve, et cetera, et cetera. So that's the kind of discussion and conversation you want to have with your doctor about that issue. Let's see here. Her Royal Highness, HRH. Do you have a normalized curve of the 700 PICL patient's amount of C1C overtraining? No, we only get post-op DMXs if there's a reason to get that DMX or if the patient requests it. In fact, we've had that discussion here on this program before. It was the opposite just last year, right? Just last year we were talking about people being concerned about too much DMX being done. And as a result of that, maybe that was about 18 months ago, we stopped routinely imaging afterwards, just because we had established that we were seeing what we wanted to see. And there was no real rationale for continuing to do these, especially since patients in general were concerned about the radiation doses. And I tended to agree, meaning don't expose the patient to additional radiation of another DMX unless there is some rationale to do that, which makes sense. Barbara, why do muscles atrophy with CCI? It's a very good question, Barbara, and it's a chicken or the egg scenario. in part, some of that question was answered by one of my old, one of the old, well, no, he's not old, but one of the physical therapists that used to work for us many years ago, who ended up becoming a professor in Chicago, an academic professor. Let me see if I can pull his stuff up. And this will give me a chance to review what he's up to, because I haven't really been keeping track of what Jim's been doing. But Jim is brilliant and has been doing this research now for quite some time. This is Jim Elliott's stuff. And he's talked about the structural changes in these upper neck muscles in people with whiplash and in people with traumatic neck injury. So bottom line is he continues to find that these muscles are atrophied on MRI. And I don't think anyone really knows yet what comes first, the chicken or the egg, but this is the guy you'd want to follow, Jim Elliott, on this topic. But bottom line is, my personal belief is what happens in CCI, that's traumatic CCI, is that these muscles can't keep up and they get so overloaded that they shut down. And once they shut down, they atrophy. It's also possible that there are nerve injuries at the time of the original trauma that shut these muscles off. It's also possible that there's another mechanism entirely, like what's called pain inhibition, and that is where muscles shut down to protect an area. Could also be marked decreased activity after CCI, etc. So all very, very good questions. I don't think anyone's gotten the answers to those questions yet, but great that you're asking them, and also great that we've got guys like Jim out there working on this problem. Because that actually came from one day, and this is 15 years ago. Jim and I were looking at upper cervical MRI muscles and noticed that just like we see atrophy in the lumbar spine, we saw atrophy in the upper neck muscles. So when he then went and did his PhD down in Australia and then came back to Chicago to be a professor, that's kind of what he focused on. So it's wonderful that he's out there, a brilliant guy, focusing on that problem and trying to figure it out for all of us. Hello, Centeno. In your opinion, are there PICL patients who might potentially benefit more from Dr. Rosa? When is the right time to see him, in your opinion, if one is steadily benefiting from PICL? Dr. Rosa is another brilliant guy in this space. And I think what happens there, so Scott has been very helpful in a number of different ways, right? Number one is he's been able to dial in with what seems to be much higher accuracy the vectors that are required by an AO or a nuclear chiropractor to get someone's upper cervical spine back in place and to give them relief. The other thing where he's been incredibly helpful for me is in identifying all the little small structures that may need additional attention in some CCI patients. So listen, if you can afford to do, Scott, and get yourself there, it's always a net positive for me. Obviously, if you're struggling on the financial side, then maybe that's not possible for you. But seeing Scott Rosa, for me, always gives me more rather than less information. And he's been very helpful going back and forth on difficult to treat patients, trying to see how best to customize the treatment for them. Mark, follow up on my question regarding facet joint second extension. Could you explain a little how the disc itself could be involved? I've herniated disc at 4 and 5 with annular tears at both. How could the disc be contributing to the stuck facets? Yeah, Mark, so that, and I apologize, I didn't get great pictures last time. I tried to, but obviously I didn't. So let's see if we can look at the anterior longitudinal ligament, because that would be one to take a look at. And regrettably, I didn't get that one for you last time. I tried, but Must have clicked on the wrong thing. Okay, this will probably work. Not the clearest image, but hopefully this answers the question. Well, that one didn't want to be copied. So let's see if we have another one. Okay, let's see if this one copies. It copies, but not well. Mark, we're striking out here. Let me try one more time here. That one's not going to work. Let's see what else we got. We'll go to the old standby. We'll go to a old netter drawing. Yeah, that one worked. Okay, so let's move the share here. Let's start looking at that. Okay, so Mark, this is what I'm talking about. So when you go into extension, note that if this is the center of the rotation here, right, in the center of all this stuff, then what's going to get the most stretched? What's going to get the most stretched is this anterior longitudinal ligament in the front of the disc. Anterior longitudinal ligament right here. Now, what's also going to get the most stretched would be the anterior fibers of the disc itself here. So those would really be where you'd focus on in trying to get the best lever arm to prevent one disc. Let's say, I'm just going to make this up. Let's say this is L4, and I'm totally making this up, and this is L5. We're going to want these anterior structures to prevent movement and extension. Now, there's also lots of other things that could happen. Posterior longitudinal ligament could be involved. The capsular ligaments, as you brought up, could be involved. The multifidus muscles, which go from segment to segment, are probably involved because they're not working, etc. But if we had to lay our bet on the structures that would cause the biggest bang for your buck, that would be anterior longitudinal ligament and anterior disc. Now, the only problem is in order to get to those structures under X-ray guidance, we have to go into the disc and into the front part of the disc. We can do that. That's fine. It just adds some additional risk. So like anything else in medicine, it's risk, benefit all day long. That's how we try to keep people as safe as possible. So I hope that answers the question now that I got a better, something better to look at as far as a diagram. Goldie, that's good info. Iodine, I'll be getting CAT scan, angiogram, head, neck, pelvis, abdominal next week, all one-time exposure. Sure, Goldie, that's great. Mark, have you seen in your clinical experience any patients with SI joint lumbar instability that contribute to C1 instability? Yeah, Mark, what I'd like to say there is we're really talking about a house. So I just explained that to a couple of patients this week. So let's take a look at what that means. So let me put this one up. So let's say we have a house, right? And we have a house. We know the house has a foundation. We know a house has walls, right? We know that there's a ceiling, and we know that the house has a roof. Now, if we get cracks in the foundation and one side of the foundation goes down, then we know we're going to have all sorts of problems, right? We'll probably start to see, let me make the walls a little bigger here. We'll probably start to see some cracks in the walls. and probably the roof, depending on how big that crack is, will start to get messed up. We might see shingles that don't fit together anymore the way they used to, or we might see little cracks in the trusses up here in the roof. So if you look at a person, this would be the SI joints or pelvic ring down here. The walls would be the core or the lumbar spine, thoracic spine, and then the cervical spine up here, and then the CCJ, and then the skull. So what happens down here can certainly affect what happens up here. So when patients and I have this discussion, and I had it twice this week with patients, is your SI joint instability helping or hurting your CCJ? It's probably hurting your CCJ. And should it be treated at the same time? Absolutely. Or if it's really severe, maybe even before we treat the craniocervical instability component. But that's the way to think about it. The SI joint and the pelvic ring are really the foundation of a house. And if they have problems, then obviously that's not good. So that's the way I think to think about this. Okay, Stacy. In addition to my problems, my mother, 79, has been told she has bone in her hip and needs a hip replacement on one side. I worry about her dying in surgery. She has a pacemaker. What can be done for that from the fix the hip issue? Stacy, if it's bone-on-bone osteoarthritis, generally autologous biologics or interventional orthobiologics, what I do, is not going to help. So regrettably, that's one of those diagnoses that's not that amenable to the type of treatment we offer. So it probably is a hip replacement, or obviously, try things that can help the hip pain. But I don't think a stem cell-based procedure or platelet-based procedure or similar or bone marrow-based procedure is really going to move the needle there. Would you recommend prolo injections pre-PICL? No, I generally don't. That's gone both ways. I've seen as many patients get screwed up by that as helped. So at this juncture, I would say no. We need to have full control of what it is happening in the neck, because we've seen a lot of patients make themselves worse by over-treating, and especially when they couldn't tolerate it. So I would say at this juncture, it doesn't seem to be more often a net positive than net negative. Ryan, thanks for the answer. It feels like a lot of physios want to explain CCI by saying the tight muscles are causing ligaments to loosen and compensate. Yeah, Ryan, I think what you're getting there is when you have a hammer, everything looks like a nail, right? So if you're a surgeon, you're more likely to recommend surgical solutions. If you're a physical therapist and you haven't been taught about CCI, you're more likely to say, well, I can help tight muscles. Hence, it must be the tight muscles that are causing everything. Now, there are some excellent physical therapists out there who have been taught the concept of CCI and understand it well, and understand that when they see that kind of patient, they've got to refer that patient on to someone who can help. So just realize that it's the hammer and nail philosophy or concept there. Okay, guys, it looks like we may be running out of questions. We're going to give you a couple minutes here to jump in and see if there's any other questions I can answer today. I do have a hard 2 o'clock Mountain stop in 15 minutes, just because I've got a meeting to go to. But if there's any other questions, feel free to throw those in there. And I've also been aware, I want to make sure I got all the questions that have been asked. Looks like I have, because sometimes the system is slow to update on my end. Mark, I sometimes lose my C1 adjustment from chewing the wrong foods. I grind my teeth and have worn them down significantly, probably in part from my SI lumbar injuries and part from cervical injuries. Your clinical experience with patients undergoing cervical injections with TMJ issues, is it posterior cervical injections with PICL treatments that would more likely alleviate TMJ symptoms? Mark, it could be either. We see TMJ overload in a lot of neck instability cases, more commonly associated with the upper neck. So it's certainly possible that that could be coming from CCI in the upper neck, that's pretty common. A lot of times we'll end up treating the CCI, whether that's PICL or posterior injections or both, and the TMJ at the same time because they're pretty commonly comorbid, meaning, and why is that? I think what happens there is that when the upper neck instability goes from a ligamentous standpoint, the strap muscles, which include the masseter and the temporalis, and all these guys up front get involved to try to stabilize the neck. And they're not really designed to do that, and that generally overloads the TMJ. HRH, what overhang do you consider CCI mild, moderate, severe? You know, when it comes to mild, moderate, severe, it's a hard concept because sometimes that doesn't link up to symptoms. And regrettably, when I do this, patients instantly assume that if I've got severe CCI, I should have severe symptoms. If I've got mild overhang, I should have mild symptoms. Not usually the case, but when it comes to just structurally, mild for us, and it's still considered CCI, is going to be kind of in that 3 to 4 millimeter range. Moderate is going to be 4 to 6, and anything over 6 is going to be severe. Those are millimeters. Stacy, can you explain what happens to C1 through C6 in someone as they age to 60 to 75 if they have cervical spondylosis? So not 100% sure what you mean there. Cervical degenerative disc disease would mean that the person loses some height of the disc because the disc loses its ability to hold on to water. Then you get more pressure on the cervical facet joints. Those tend to then become osteoarthritic. Then with all of that, you get a lot of degenerative instability. Degenerative instability means that things move around too much. You can get atrophy of the stabilizing muscles, laxity in the surrounding ligaments, etc. So that's generally what happens. Now, some people through age 60 to 75 get very little of that. Other people get more. And if you've had a thoracic and partial lumbar fusion, which is what I think you talked about, then you're going to have more adjacent segment disease. So that means that all of these guys are going to have to work harder to compensate for the lack of motion because of the Harrington rods. So you're more likely than not to get more degeneration over time in the neck and below L4 than someone else who doesn't have a fusion there or a long fusion. Becky, how do you diagnose thoracic instability? You know, Becky, that's a harder one. There really isn't any imaging that I can send you for. There are some telltale signs, however. So we can see facet joint hypertrophy, which is where the facets get arthritic and big. We can see the ligamentum flavum start to bulge out and get bigger or have hypertrophy. We can see the disc bulge at that level, etc. So from that standpoint, we can diagnose it that way. Now we can diagnose rib instability, but that's not on any test. That's really a hands-on physical exam, and it's kind of a specialized thing, meaning that that particular person has to be really, really experienced in diagnosing rib instability to do that. And then Stacy, yes, definitely get an updated DMX there. Mark, I get twisting rotation of my lumbar vertebra, which ligaments would most likely be responsible for the twisting of the vertebra. You know, Mark, I think those intertransverse ligaments that we talked about would be a good bet, but also you have to look to see if there's a side bend or scoliosis, because when the side, when you get side bend or scoliosis, the vertebrae always rotate because all side bending causes rotation of the vertebra. Those are what's called a coupled motion. So when side bending happens, you always get rotation. So that's another thing that can cause that. So we'd have to see if there's scoliosis there. Stacy Gilbert, which clinic do you work from, Broomfield or Lone Tree? I'm in Broomfield. Dr. Heisey, who's excellent, is down in Lone Tree. Dr. Money also goes down there. But the Broomfield Clinic is our main facility, so that's where most of our doctors work. But we have 2 doctors that are down south in Lone Tree. Okay, guys, any other questions here? Come up to the last 10 minutes. I'm going to take a drink of my much needed green tea. Any other questions? Going to give it another minute or so, and then we'll wrap it up. Thanks, Stacy. Mark, how can you diagnose if the intertransverse ligament is responsible for the twisting, hands-on, or MRI? Well, the first thing we'd have to do is to make sure there isn't any scoliosis. And if there's just one segment twisting, then there could be response. That could be a lot of things. Could be intertransverse ligaments. Could be that there's a fascial injury in the thoracodorsal fascia. That kind of stuff. So those are so that would be a combination of MRI, ultrasound, and hands-on exam to try to figure that out. But it's not always apparent. It is something that takes a little noodling to make sure you've got the right diagnosis there. HRH, what range of improvement have you seen on an overhang? Yeah, so again, as I said before, generally what we see and what we'd like to see is about a 1/4 or 25% improvement on average with each one. So if we're starting with 8, it's a nice round number, 2 millimeters per treatment. Now, there are times that we've seen more than that, and there are times that we've seen less than that. But on average, that's what we look for, and that's generally what we've seen. I've had prolotherapy, C2 down to T1, really helped with radiating pain in the DDD 5-6 area, but I still have crunching and pain in my entire neck after sleeping weird, which osteopathic manual medicine does help relieve the pain by releasing muscles. Are the muscles tightening still an identification of instability? Yes, Stacy, probably. I mean, obviously everyone's different. Sometimes it can be nerve irritation, etc. But in general, it's degenerative instability. There also may be a joint that's painful at that level. So in that case, you would have to do something like specifically under x-ray guidance, inject PRP into that joint, or an irritated nerve that might also be a part of that, i.e. you sleep the wrong way because it's still a little unstable, the nerve gets tweaked, and then boom, everything blows up from there. So those are things to think about. Yeah, I did treat the TDF, Mark, but again, this is something a little more specific that we may want to discuss one-on-one and take a look at your imaging so that we can try to get our arms around what you're talking about. Goldie, I just say that doctors tell me tarlovs are common, don't cause symptoms, but I understand that is not always correct. Yeah, Goldie, you have to be a little careful with that statement, meaning doctors have to be careful with that statement, because in general, small tarlov cysts generally don't cause issues, meaning that we see them in people incidentally who don't have issues at that place. Having said that, I've seen bigger ones trap the nerve right up against the sacral canal wall. And if that fits with someone's clinical symptoms, then it's causing symptoms. We can even block the area to try to take the symptoms away, meaning inject, from a diagnostic standpoint, numbing medicine. So those are the kinds of things that we would do to see if yours are symptomatic. I'm not saying they are, but there are definitely times that they're symptomatic. And there's an exception to every rule here. And so the question is, are you that exception or are you the rule? That's the big question. Stacy, I have same issues as Stacy Eskins after sleeping on my side. Yes, Stacy, so that's generally degenerative instability. And the reason why it happens at night is because when you sleep, the stabilizing muscles are turned off. And obviously we get into deep sleep and we may have our head a little different direction than we probably optimally should. And then as the muscles relax, things kind of get out of place. And as they get out of place, nerves get pissed off, joints get pissed off, the disc gets pissed off, etc. And then that, it all breaks loose from there. Okay, guys, so I'm coming up on my hard stop here. I'm going to start winding this up. What we talked about today was the degenerative disc disease study that we have, that we're starting. Definitely reach out to Erin if you think you are a candidate for that. And I'm going to put her information right in the comments here. So I'm going to give you her email address. It's edodson, D-O-D-S-O-N, at Centeno-Schultz.com. I just put that in the comments. So if you're interested in the study, please go ahead and reach out to Erin, edodson, at Centeno-Schultz.com. It's a no-charge study. It focuses on patients who have been told they need a lumbar fusion. And obviously the goal of the study is try to see if we can avoid the need for lumbar fusion by using this orthobiologic technique. Good news is we've been using it for years and we know it generally works, but there's, what do we think, what do we know, and what can we prove? So now we're in the what can we prove side of that calculus. So thanks so much for watching. We also talked about some interesting imaging on the C2 dorsal root ganglion, and hopefully we can get to the point where we can use some interesting imaging techniques to see otherwise invisible injuries. And that's always been an interesting one for me. And then H. Brown, had a Regenexx procedure done on my spine at UCLA, could not be happy with the outcome. Well, great. Great to hear. So guys, you have a fantastic weekend. I will be here on Monday. We'll be talking about CCI topics on Monday. So if you're interested, drop by. I don't know the topic yet. If you have any topics you'd like to hear about, then don't hesitate to leave some comments here. And Carol Yates, who is our social media manager, can go ahead and take a look at those. So thanks so much for watching. Thank you for taking the time today, and have a great weekend.